Hello, everyone. Thank you so much for joining us. We are so excited that you're here. You are at Living SickleSMART, our virtual education session. My name is Ray Blaylark, and I am the Executive Director at SickleCell Foundation of Minnesota. And so we are excited about tonight's session. Before we begin, I want to make sure that you all, are aware of where you're at and what we're here to do tonight. We want to make sure that we always say special thank you to our sponsors. Let's make sure we're sharing the right thing. There we go. We want to make sure we say thank you to our sponsors. So Children's Minnesota, Agios, Memorial Blood Centers, Be the Match, and of course, our own Minnesota Department of Health, the Sickle Cell Data Collection Program. We're very, very excited. In case you're not sure where you're at, let me help you. Today's session, Global Perspectives in Sickle Cell Disease, and we are honored to have a special guest with us, Dr. Stephanie Ibamire. And we are going to walk through much of her work and what she is doing in the sickle cell space in sub-Saharan Africa and elsewhere, and what that means to our worldview in understanding what's happening in sickle cell disease globally. So I'm going to stop sharing. I want to make sure I bring on Dr. Ibamire, and I want to introduce her to you. Dr. Stephanie Ibamire is an assistant professor in the Duke School of Nursing. She received her PhD in nursing research from the University of Cincinnati. Dr. Ibamire is a registered nurse with experience in global health capacity building and clinical education related to sickle cell disease and other chronic diseases. Her research program focuses on building healthcare provider capacity to deliver high quality and effective care for chronic disease symptom management. In particular, Dr. Ibamire is focused on improving the clinical model of care for sickle cell disease in low resource settings, both in sub-Saharan Africa and in the United States through tool adaptation, implementation science, leveraging technology, community engaged research. Dr. Ibamire is passionate about addressing healthcare disparities in partnership with communities to co-create feasible and sustainable healthcare interventions for and with patients, providers, and the healthcare system. I love that because what you're talking about is community, and that's what we are all about. When you create community, you create infrastructure, you create stronger networks in order to do the things that we need to do. Because what we are pulling some pretty big weights, but it's not impossible. I brought you here today because I learned about you earlier this year, and I was so impressed, not only with the work that you're doing locally, but how you bring the work that you're doing locally and you bring that into those low resourced areas. And so without further ado, I want to introduce to you Stephanie Ibamire, Dr. Stephanie Ibamire. I also want to remind you all that you can feel free to chat with one another in the chat box. And if you have questions, please use the Q&A box that is down at the bottom of your screen typically. Also, just in case you didn't know, in about 24 hours, this episode is being recorded and will be uploaded to our YouTube channel, and I will put the address to that in the chat box. And then please add your questions throughout this session. We love the interaction. We love being able to hear what you're curious about and address your questions and your concerns. So, Dr. Ibamire, I'm going to turn it over to you. I'm going to stop my video and go on mute. You should be able to share the screen now.
Yes, ma'am. Thank you so much for that really nice introduction. I should take you around with me everywhere to read that to people because it sounded so distinguished. I think it's just because you're a really awesome human being. It's really nice to be here with you all this evening. Thank you for having me. I do think you should be seeing the title slide right now. And as Miss Ray said, my name is Stephanie Ibamire. I'm a faculty in the Duke School of Nursing. And today I'm just going to do a brief discussion about the global perspectives that I have, at least in and the information we know about sickle cell disease in the global community. And at the end, though I don't have a slide for it, I just want to talk a little bit about what I see for the future, what work I'm doing. And I want to hear from you all as well about your thoughts. I don't have the answers to every question. And so I do invite a thoughtful and intentional discussion because we are all here to learn and grow together. So with that said, just a few objectives in this presentation, which is really to talk about the epidemiology of sickle cell disease and why it is the way that it is. And then also talk about the differences in diagnosis and treatment availability in sub-Saharan Africa, which is pretty point blank different. And finally, I want to just share some of the experiences I have come to learn about in my research. So to start with, we're going to start here really with what is epidemiology, right? So epidemiology is really the study of disease prevalence and incidence. Prevalence meaning how many people have the disease, and then incidence meaning how many new people are diagnosed with the disease. And that's any disease, okay? One important fact to know, and is not commonly, I think, known in the United States, but sickle cell disease is the most common hemoglobinopathy, which is a big word to say hemoglobin disorders. But it's the most common hemoglobin disorder in the world. Here in the United States, it's estimated that about 100,000 people are living with sickle cell disease. Now, I will preface that with that number was developed about now 12 years ago. And so the number of people has most likely increased here in the United States. According to the evidence, there will be about 14 million people, newborns born with sickle cell disease between the year 2010 and 2050. So we're about halfway through that time period. As of 2010, it was estimated that there were going to be about 300,000 children born with sickle cell disease annually. However, it should be noted that more than 200,000 of those children were going to be born in sub-Saharan Africa. And so we know that the greatest number of people with sickle cell disease are being born on the continent of Africa. However, many of the interventions that are used for sickle cell disease don't always make it to that context. I'll get into that later. It is estimated that the total number of children born with sickle cell disease will increase actually to 400,000 a year by 2050. So this number is just ballooning, if you will, with each year that passes. I want to highlight here, though, that there are 3 countries that have particularly high numbers of sickle cell disease births annually. So as of 2010, again, 2010 was a big year for understanding sort of the numbers associated with sickle cell disease and how many people have sickle cell disease. So in 2010, we came to understand that about 85 to 86,000 children are born with sickle cell disease in Nigeria. About 38 to 40,000 children are born with sickle cell disease in the Democratic Republic of the Congo. And then also about 42,000 children are born with sickle cell disease in India. These are the top 3 countries for sickle cell disease births. Many people actually don't know that sickle cell disease occurs outside of the continent of Africa. And so I always bring this point up to show the expansiveness of this disease and the people that it affects. Just to connect to some of the research that I've done in the past, and I'm working on now, we estimate that in Sierra Leone, which is also in West Africa in the same area as Nigeria, we believe that there are about 5,000 children born with sickle cell disease every year there. It is a much smaller country compared to Nigeria. And so that number, when you look at the percentage of people being born each year, the number is actually quite close when you do corrections for population size. I should also add that these numbers that I'm telling you we could possibly bet, if you will, that they're a underestimation of the sickle cell disease prevalence. Remember, that's the number of people who have sickle cell disease in the world, mainly because, and especially because across the continent of Africa, there's not a national screening program like we have here in the United States that would allow us to effectively track the number of newborns that are diagnosed with having sickle cell disease. So these numbers are based on estimations of sickle cell trait. So sickle cell, or sickle hemoglobin, I should say, is often written as HBS, which is what you see here on this slide, is noted in this diagram and can generally be found in sub-Saharan Africa, right? And the green that you see in this particular diagram represent areas where malaria, which is a disease that is transmitted via a specific mosquito. These green areas show the density, if you will, of malaria prevalence in these certain countries. So you're looking at basically around the equator is where you are finding large amounts of malaria. We call that an endemic condition because those are disease processes that are just common and constant in that area, kind of like COVID is now. And hence the move and changes in public health practices because COVID has become endemic in our communities. The red parts of this diagram shows the frequency of sickle hemoglobin alleles, and those are like one copy of the sickle hemoglobin gene. And so the genetic distribution of sickle cell hemoglobin alleles is thought to actually be related to malaria. It's called the malaria hypothesis. And this hypothesis suggests that the actual mutation that causes sickle hemoglobin occurs because of an evolutionary advantage that having sickle cell trait gives to a person. So in sickle cell trait, I want to be clear, is having one copy of this sickle hemoglobin gene. To have sickle cell disease, you must have two copies of the sickle cell gene. So having only one copy seemed to protect people against severe malaria infection. And so naturally, the body and the, over time evolution selected sickle cell trait as an advantageous blood type, if you will, and not like a type O or type A, but hemoglobin type, I should say. The other thing I want to highlight here too is you can see that places where maybe malaria is not quite as common also have some hemoglobin, sickle hemoglobin frequency as well. As I mentioned, sickle cell and sickle cell trait are expansive. They are not only in the continent of Africa or only in the United States, but this occurs in many different places. And one of the reasons we believe that this is the case is actually due to a very dark part of our collective history, which is the slave trade. Aside from that, normal migratory patterns of people coming in and out of the continent of Africa, in and out of Brazil, in and out of places like India, and moving to other parts of the world. So what this means is between the malaria hypothesis, slave trade, and other migratory patterns, it means that you can find sickle cell trait and sickle cell disease and other sickle variants like sickle beta thalassemia in places like Greece, in places like Italy, Saudi Arabia, Brazil, as I mentioned, India, as you have seen, and here in the United States. So in other words, it's really important to understand that sickle cell disease is not the disease of only the Black person. Sickle cell disease is really driven by ancestry rather than your skin color. I want to make sure that that is clear. It is true that the majority of people who are affected by sickle cell disease do come from the continent of Africa, but I wish to push this to be more of a conversation of ancestry rather than your race, because as we know, race is a social construct, okay? So I'm going to move forward now and talk a little bit about an infographic that comes from Fogarty. And I think this particular infographic makes all these numbers that I was just talking about and this idea of how did sickle cell come to be more tangible. So you can see here, it says in Africa, 1,000 children are born with sickle cell disease every day. In comparison, we believe that about 2,000 children are born in the United States with sickle cell disease every year. This says every day. However, as you can see, this is nearly 6 times higher, like higher than in sub-Saharan Africa. So if we're talking about 1,000 children a day versus 2,000 children a year, the disease burden, the number of people who are affected is great when we're talking about sub-Saharan Africa. Now, this particular image is called a cartogram, and I believe that this image also brings this idea of the number of people affected to life. It might be hard to tell in this picture, but this is actually a picture of the globe. This is a map of the world. And what you're seeing on the left-hand side is actually Alaska, United States, South America, Central America. And then this really large region here is actually Africa. And why is it distorted? You might be asking me. Why is that happening? Well, these are geostatistical maps, and they are predicting that by 2050, the prevalence, so the number of people affected by sickle cell disease, will balloon, signaling essentially the need for more disease interventions, right? And so this ballooning of Africa is to say, in comparison to other places in the world, the number of people who will be born with sickle cell disease is going to increase drastically. And the number of people who have the disease is going to increase drastically in these particular areas that are distorted in this image. So you can see, as I was mentioning before in this particular chart, that the greatest burden of sickle cell disease is on the continent of Africa, where Nigeria is estimated to have the highest number of sickle cell disease births out of all of the countries in the world. We also believe that Sierra Leone should fall somewhere between Niger and Guinea, okay, on this chart. These data are particularly important when we're talking about the disease complications that accompany sickle cell disease. All of these complications, as you see here, complications of stroke, retinopathy, acute chest syndrome, leg ulcers, dactylitis in children, priapism, something that we don't talk about enough, cardiac complications. All of these things spell increased disease morbidity. So your disease condition worsens, and unfortunately, mortality, premature mortality. So please take note that the effects of repeated vaso-occlusive episodes, so the pain crisis, every time that happens, chronic inflammation results, and it causes injury to the vessels. And that is why we can see sickle cell disease affecting nearly every organ in the body. So no part of the body is left unscathed by this. And so I have taken, and Ms. Ray knows this, I've taken to talking about sickle cell disease vaso-occlusive episodes as tiny heart attacks that occur all over the body, except we never know where the attack is actually going to occur like we do with heart attacks. And so for me, describing it that way opens a lot of people's eyes and minds to the fact that this is really a disease that should be treated with urgency when people arrive to emergency departments or to their the clinical offices of their care providers. The importance of our collective efforts to improve the clinical model for sickle cell disease management across Africa is even further evidenced by the low rates of childhood survival in sub-Saharan Africa compared to other countries. And so you can see here, we really predict that only about 10% of children will survive with sickle cell disease on the continent of Africa. When you look at places where a lot of the research is occurring, they're looking at 99, 94, 84% survival of children past the age, usually of 5. And so as noted in this particular graph that I'm showing you here, that life expectancy even is spilling into adult age. As you can imagine, if we're not doing a good job of identifying who has sickle cell disease, and then also do not have a care model for those who we do diagnose with sickle cell disease, their chances of surviving into adulthood are drastically thwarted. So as you can see here, that adult survival, unfortunately, for individuals living with sickle cell disease, even in the United States, okay, does not break 60 years. And it's something that I was always very harrowing about this is when you're looking at this graph, two things. In Nigeria and in Sierra Leone, the age of survival is about 20 to 30 years old. And then there are some countries that simply we do not have the data available to us to understand what exactly is the life expectancy, which just speaks to how much more capacity building we need to do to not only take care of people with sickle cell disease, but then also to track information about them so that we can know how to improve care. So, and this is a duplicate of that graph, but as I was saying, I take great pain when I see this graph, mainly because there is work that can be done to address this. And I find that this is an issue of health equity, not only for those in the United States, but most especially where the disease burden is the highest, which is the continent of Africa. It's something that drives my my wish for improvement for sickle cell disease here in the States, but then also especially in West Africa where I do my research. So with the passing of the National Sickle Cell Act, and I see a chat here, is the life expectancy for those who survive through age 5 or for all with sickle cell disease. So on this slide here, this is for those who, these are for adults. This particular slide is for adults. The life expectancy of children is not well characterized, unfortunately, for the same reasons that we have poor outcomes in adults, which is essentially having people who are actually caring for them that are taking good, collecting data, helpful information that we can use to actually quantify life expectancy in children. Well, what we do know is that we estimate, especially in areas of high prevalence of sickle cell disease, about 50 to 90% of those who are diagnosed as children, most of them will not make it past the age of 5. So we talk about childhood life expectancy with sickle cell disease in the form of the percentage of how many people we are estimating survive. I hope that helps, Carol. It's nice to see you here, by the way. So you're welcome. With the passing of the National Sickle Cell Act in 1972 here in the United States, this began a process, right, of establishing these sickle cell centers and ensuring that there was infrastructure that was necessary infrastructure for newborn screening to occur, right? And so we had some newborn screening, but sickle cell disease was not part of that. And so by 1975, as you'll see here on this nice little timeline, New York State was the first place to actually establish a newborn screening program. Now, this particular fact always baffles me too. Fun fact, all 50 states did not have newborn screening for sickle cell disease until 2006. That was only 16 years ago that newborn screening was a completely national scheme. Every state was able to perform sickle cell disease screening. So that means that even in the United States, there are some people who might not know their sickle cell status. And this is where community organizations like Sickle Cell Minnesota and Sickle Cell Disease Association of America and the others come into play with helping us capture those people who may have been lost or in the cracks, right? In this time period of 1975 to 2006, who may not have been screened. So what I would say about the state of screening for sickle cell disease, which, as you can imagine, without having a way to screen for the disease, there's no way to treat the disease, and there's no way to preserve life. I would say that much of the screening across the continent of Africa is kind of like the United States before 1975. That is, there's not a universal approach right now to screening or diagnosing. Screening and diagnosing I'm using interchangeably. Sickle cell disease across the continent of Africa. There is some limited evidence that Ghana is working towards a national program for newborn screening. However, one of the difficulties is this type of work requires multi-level interdisciplinary action to put it into place. And then it also requires a very serious infrastructure. If you are using the models that have been developed in what we call high resource areas like the United States and United Kingdom, much of the laboratory equipment that is necessary to do this screening depends on electricity, which is not always a constant in some of these contexts, especially where I would like to do my work, which is in the rural area. Some of the things that are necessary, the supplies and the tools and the reagents, et cetera, that are necessary are simply not affordable for some places across the world to access. There's definitely evidence coming from Uganda and Angola from the work of Dr. Russell Ware that shows that it is possible to scale up newborn screening that looks like what we do in the United States, but those efforts took many years, decades to put into place. And so thinking about now, what can we do, right? We've been charged by the World Health Organization to think about what ways could we mobilize and institute newborn screening across the continent of Africa that could happen now. And so therefore the point of care tests, things like sickle scan or hemotype SC, have been lauded as a way forward in newborn screening for scientists like myself and clinicians like my brothers and sisters on the continent of Africa, as a means of advancing sickle cell disease screening in these areas where resources are tapped, but knowledge is not is available, and people are eager to learn and advance the care model to at least diagnose the disease. So then let's say we are able to achieve this goal of using point of care testing, and we're able to identify people with sickle cell disease. This is great, but the ethics of doing genetic screening carries with it the obligation then to follow that diagnosis with treatment. And so there's tons of ethical discussions that can occur about this, about diagnosing someone with a disorder without having a plan of care or a care model in place already. And so on this slide, what I'm trying to do is really show you what it looks like to treat sickle cell disease. And I'm just using these two countries as a comparison, where in the United States, as I mentioned, we had the National Sickle Cell Disease Act, and then we had these comprehensive care centers develop. And among that, in that time, it was a time of developing the ways in which we were going to care for sickle cell disease. And then we had in 2014, the National Heart, Lung, and Blood Institute, the guidelines for sickle cell disease management, which have all come together to develop this care plan. And of course, hydroxyurea being at the helm and the original medication for sickle cell disease treatment, because of its ability to produce hemoglobin F. These are the treatment plans that people have available to them here in the United States, along with 3 new medications, right, that have come to market, though we hear now, about different issues of insurance coverage and costs and things like that. However, the science is advancing to have these 3 new medications that can increase hemoglobin and reduce pain crises. Also as part of the care model, we know in the beginning stages in the United States, infection was one of the ways that we were losing people with sickle cell disease. And so vaccination against pneumonia and has been included as part of this care model to ensure that people are not dying from pneumonia that then spirals into acute chest syndrome. So this is very interesting because this is now sort of the place that we find ourselves, right, in sub-Saharan Africa. It looks like the United States period of time in the 1920s and 50s before the introduction of these vaccines. And so what we're seeing now is a push across the continent for infection prevention as one of the primary means for reducing mortality related to sickle cell disease. So along with this, pneumococcal vaccination, my experience has been that you can see the penicillin prophylaxis as well, which is also used here in the United States to prevent infection. There's also the use of vitamin C to support the immune system, as well as malaria prophylaxis, which is something that would not be commonly used right here in the United States, as this is not a place that has malaria, an endemic malaria issue. The difference in terms of pain treatment, if you will, is quite stark. In the United States, my experience has been the use of opioids to handle pain crisis and to treat chronic pain that comes with sickle cell disease. And that just simply has not been my experience in Sierra Leone, and although that has to do with supply chain issues, it is really not common for opioids to be used, at least in the rural communities that I have visited, and even in the city, for pain crisis. Many things, the common things that are used are things like diclofenac and ibuprofen. Paracetamol is like a Tylenol type medication. And so those are the ways that people manage pain. Massage and heat are very common means of managing pain in the rural part of Sierra Leone. And so these are some of the innovations, if you will. And if I have time, I'll talk about a story, or you guys can ask me in the chat if I forget about the story of how innovative people have become in Sierra Leone, particularly to care for themselves while they're in pain. And then you can see here in Sierra Leone, it's common to prescribe folic acid for red blood cell support and the healthy development of red blood cells. You'll notice that on the Sierra Leonean side of this slide, there's not really a discussion about curative therapies. And that is just as a function of infrastructure and the need for capacity building for an infrastructure to be able to handle care of a person who's undergoing bone marrow transplant. And that will come in time, I believe. I think I like to be hopeful about this, because even just the advent of using or doing infection prevention and supporting the immune system with vitamin C and the use of folic acid, all of these things only just started recently. And so there's an incredible potential for growth and development of interventions that can support the use of disease-modifying medications like hydroxyurea and the others, as well as one day things like bone marrow transplant and hopefully gene therapy. So I'd like to just bring myself to a close here by sharing some of the experiences that were shared with me by patients who have sickle cell disease in a rural part of Sierra Leone. These are quotations that came from some previous qualitative ethnographic, so field work, living in the community. I have found, thank you, Bella, it's nice to have you here, appreciate you. This slide really represents both the cultural beliefs and the cultural values that impact sickle cell disease management in this particular community that I lived in for a number of weeks. There are a number of titles here, and I can go through those quickly. Here, the title of "It Is Not Easy" refers to the different situations that people found themselves in, or people who were caring for those with sickle cell disease found themselves in, that were difficult, and it required them to persevere and push through despite whatever difficulty it is that they were experiencing. So you can see here from a professional caregiver, so someone who works in the health system, they said, when the sickle cell patient is in crisis, we don't have hot water rubbers or bottles. So those are those hot water bottles. We use the water bottles, the thick ones, the bigger ones. We warm the water, we improvise, we put warm water in them. We put up the bedding. So they set up a bed and they put it right around the bedding, and then you cover the patient. And this is one of the innovations I wanted to talk to you all about. They use a technique in traditional medicine of steaming people when they're in the middle of a crisis. And I sat with myself for a while trying to figure out why would you heat someone up who's in pain? And when you think about what a vaso-occlusive episode is, it's blockage of vessels, right? This is an area where the sickle cells have accumulated, and it's blocking blood flow. Well, as many of you know, in the summertime, sometimes when you go outside for a while, it's been hot, your legs get really swollen, right? Like they puff up, and that's because we're dilating our vessels and some of the fluids sort of leaking out into our ankles, right? But the idea of using heat to expand the size of a vessel so that blood flow can pass through is really what they're getting at in this quotation. And to give reverence to the difficulty that they must have passed through to even come up with this idea, and then to implement it and see such drastic changes in patients. I got to watch this happen, actually. And within an hour, the patient was up and moving around, had hydrated, had taken some Tylenol, and the patient was back to life. And so it's an incredibly beautiful experience to see what can come out of what we call low resource. And so I think that there are some innovations like this one in particular that could be so beneficial to us here in the United States, that I think, as part of my work, I hope to be a face so that I can give voice to and be a voice for this type of work that people are already doing that is not well characterized in our scientific literature. I could talk about this forever, but I hope that this has given you an opportunity to read some of these quotations and the things that people go through, the way that people believe, right? For example, in the spiritual sense, if you use this spiritual sense, you look to God, as this person says. I hope to God that if God can allow this in our body, so God can also make it go out of our body, so we will be well. So it's almost like it's not only just a belief system, but also a coping strategy through which people are managing sickle cell disease in their everyday life, right? There's also the people who have been influenced by our biomedical medicine and see sickle cell disease for just exactly what it is scientifically, a genotypic issue, a genotype monogenetic mutation that has occurred. And so you see here in this quotation under this idea of the Western sense. So the Western belief, sickle cell is something that is in my family, right? Because the man I had children with has sickle cell. He goes into the pain, and me too, I have it. So the children we give birth to are SS. Like this is SS, pointing to one of the children. I have a carrier, which is sickle cell trait. That's what makes sickle cell to be in us. So even with a brief education here and there, people do understand what sickle cell disease is at the molecular level. But it's also important to not only just understand what sickle cell disease is at the molecular level, but also when you have these beliefs and you have these cultural values that inform your life, what practices do you use then to actually take care of yourself? And so aside from what, medications that we can give, what are people really doing to take care of themselves? And so this was another part of the study that I conducted that talks about what we call the country way, which is using more of traditional medicine to deal with sickle cell pain crisis. And something of note, after completing this study, I went back to the literature and found that there are certain vegetables and leaves that were described to me in this study that have been shown to actually have anti-sickling properties. So again, yes, exactly. That's where I'm going right now, Ray. Again, there are certain, so for example, in this quotation, they talk about in the country way that they tie the person up. And so by tying the person up, it's so, for example, if you're having crisis in your elbow, they will straighten your arm and tie your arm to be straight. And then they go and it says they will go and bring potato leaf, and potato leaf is literally that. It is the vegetation that comes out from the potatoes that are being grown. So these are like sweet potato leaves, and they wash the leaves, and then they make you drink the water from washing the leaves. So they make sort of like a tea. Sometimes this tea makes people sick, and that's what this statement is. So my stomach gets swollen. Yeah, yes, exactly. And I think it has something to do with the anti-sickling properties of some of these leaves, Carol, is that I'm wondering if there's some sort of dosing of these leaves, maybe actually that would be more beneficial and not lead to toxicity and liver damage. But that's a whole other study. But they do use plant and herbal medicine. Some people find that the teas that they make from these leaves actually help them. But then there are some that make people very, very sick. And I wouldn't be surprised if we did a panel on this particular person that made this quote, if that person wouldn't have the liver damage or something like that. And so Carol was asking, or was giving a statement, right, that in children we see a lot of toxicity and liver damage with herbal native medications in Sierra Leone. And Ms. Ray had asked, what about plant and herbal medicine in this community? And so, as you can see here on this slide, that is used, and it is not uncommon, and is often a first stop, actually, for patients who have sickle cell disease, because it is the most accessible. These are things that are grown in people's backyards, if you will, backyard in the sense that we would use it here, but on their ground, where they live, they're able to grow these vegetables, and they are known to have some medicinal effect. What that exact medicinal effect is perhaps has not been quantified, but for them, it is something that has been done traditionally, and so they go to that first. And then you also have people who, again, have been exposed to biomedical practices, right? And so in the Western way, you see people talking about, doing blood panels, so screening them every month, checking their hemoglobin, making sure their hemoglobin is at the right level for that particular patient, giving them their routine medications, which is what I showed you on the long-term treatments of sickle cell disease care in Sierra Leone. So that includes penicillin, right, vitamin C, folic acid, all of those things that you would do to prevent infection and support the immune system. Those practices happen as well. But then there's this very interesting state in which some people were doing both at the same time. So I mentioned massage before, and this quote under the hybrid way is an explanation of how both biomedical practices, so giving them pain medication, which is what she's referring to in the last line here, but then also using traditional methods of mentholated oil. Dani is goat fat. So Dani is goat fat. And then she said she called it Chinese water. And I was not able to find this while I was in the country. But she uses that to massage her child while the child is in crisis. And then wrap him up in warm clothes. And then provide medication and let the child rest. And so this is where you see a mixture of cultural practices coming together in this particular community. Finally, on the other side of this screen, where this is really a description of what it's like to live with sickle cell disease in this community. And some of the stories that I heard were really harrowing. But I think it's not really that different than what we hear from individuals, from sickle cell warriors here in the United States. There is stigma attached to having sickle cell disease. There are difficulties with receiving care that is appropriate and adequate and timely. And then sometimes, and this might be the place where there's a bit of a difference, but maybe not. There are things that we have to do to take care of ourselves, like avoiding extreme temperature change, or making sure that you're dressed well for the weather so that you don't induce a crisis, or making sure you don't overexert yourself. But then there's also a group of people that I met in Sierra Leone who really struggled with their diagnosis and understanding how to grapple with it. And so that's also captured in this domain of owning and disowning what they call the sick. Okay. So I just want to, before I stop, I just want to, because I don't have a slide for this, I just want to say that there's tons of hope in the midst of all of these data that I have talked about here in the global space. There's work that I'm doing related to trying to develop a clinical model for sickle cell disease with the use of evidence-based algorithms that could support clinicians and allow them to provide healthcare that is based in the research, and also, and I think even more importantly, based in the context. And so I'm working to get a project off the ground that is related to just this, understanding what clinicians understand about the disease in rural areas and in the city in West Africa, but then also pulling together a group of clinicians who do have sickle cell disease expertise and asking them to work with me and have us develop or adapt existing tools so that they can be used in the context according to the resources that are available in country, rather than taking a tool that was developed in the US and then just dropping it in sub-Saharan Africa. And so there is hope. There's a lot of work going. I just saw, I think it was a couple of days ago, I believe it's in Kenya, they're launching a newborn screening program in one of the major hospitals in Kenya. It's a very exciting time for sickle cell disease. And I think because we're all so passionate about the health inequities that we have seen over the years, I think we are really moving the needle. Though it may seem slow, we are moving the needle to improving the disparity that is between the United States and sub-Saharan Africa when it comes to sickle cell disease management. And so I at this time, I'm really open to your questions and maybe comments, maybe even what you're doing in your communities right now to advance care for sickle cell disease, and maybe some of the stories that you have about sickle cell disease. That, I am a scientist, I'm a nurse by training, but I by no means know everything. And so I love to hear from you all. And I really thank you for your time.
Wow, Dr. Abimiri, this was incredible, because I think that, it's very easy to fall into a form of privilege here in the US, where we get so hyper focused on what we don't have. We don't recognize that even what we do have is, generations ahead of many other countries. But I love that you ended it on a positive note, because we're not where we used to be, right? Mm-hmm. No matter the situation, it's getting better. We are working towards it getting better. One of the questions that I have, and then I know that we also have individuals from other countries that are with us tonight, so I do want to hear from them. But one of the questions I have is, when we try to duplicate the North American way, right, in low resourced areas, can that be sometimes what's taking so long? And instead of, like you alluded to, what are the resources that are available? What kind of infrastructure can be built in the now versus what we're building towards? Because I feel like there's so much that we don't do while we're waiting to figure out what we can do. And maybe I'm off because I've not been to these areas and I'm not as aware. But I just think that sometimes North America is very complicated.
Yeah, it is. I mean, it really is. And I think you're spot on, right? And this is why I have such an interest in implementation science, because I think sometimes, and I would say more people are aware of themselves and don't do this as much. But even as few as 5 years ago, we still had people who were trying to take interventions just as they are from the North American side of things and take it and put it in the context of Africa and then ask, why isn't it being sustained? Well, it's not possible because the resources are different. And so my big thing has been what infrastructure already exists, right? So for example, a lot of people talk about how do we plug in sickle cell disease diagnosis into an HIV program that is already in place, right? And how do we use the champions for HIV and their infrastructure to now be voices for sickle cell disease? And so it's thinking outside of the box a little bit about where are these resources and where do we get them from and who our partners are, right? Our partners might not always be a hematologist. That's another thing that I tried to explain to people in Sierra Leone. I believe it's 168 doctors for 7.1 million people. It could have changed a little bit, but you know, when you start doing that math, it doesn't add up. And so it might not be a hematologist, it might be a nurse. And that's one of the places that I focused is how do we leverage the healthcare professionals that we do have who are eager to learn, who are many, and then use that. Right. Yeah. Yep. Yep. So we just have to start to maneuver in a way that does not conform to the way it's always been done, and also does not always conform to the way it is being done in other places. This is the importance of community assessments. This is the importance of understanding, first of all, what the actual problem is. Now, Ms. Ray, I'm going to go off here for a second. I have what my research agenda is, right? I look at the literature and I think, wow, there's a gap in this very particular area in sickle cell disease. I'm going to fill it. I go to the community. I try to implement said intervention. After a year, it all flops. Well, why is that? There's not clean running water in this community. And I'm asking people to take medication. And when they take the medication, they get sick. And so they tie it to that medication when really it's the parasites in the water. If I would have taken the time to ask, what is the crucial issue in your community right now? I might have heard, you know, our kids really get sick, even though when we ask them to hydrate, you know, they seem to just keep getting sick, and it's diarrheal illness, right? The solution for that is not hydroxyurea. The solution for that is how do we get infrastructure for clean running water? And then maybe it's time to talk about hydroxyurea. So those sorts of steps that should occur as part of a community engaged participatory type research model are the kinds of ways that we should be thinking.
I love, you know, the fact that you say that is so important. Because I think that you can have the best of intentions, right? And you know, I think about, again, us here in the US, we're here in Minnesota. Certainly our numbers don't look like the South, but even, you know, some of the implementation that they are carrying out in the South may not be what works here up in the Midwest, right? So all the more when you are talking about, you know, not just not just other countries, but you're talking about different resources. Now you can call it low resource, moderate resource, what their resource, they have limited resources, and those resources typically don't reflect what we have access to. So, this step-by-step process is really starts with, if you want to know what people need, ask them, right?
Yeah. Imagine.
We have complicated that in incredible ways.
Yeah.
We have work groups and alliances, and we convene in big meetings and to talk about what we can do for these people. And no one ever stopped to just say, hey, in your perspective, in your lived experience, what is your greatest challenge in your community?
Yeah.
And we could understand so much, because I would love to just, I would love to be able to collect, hydroxyurea bottles from all the folks who ain't taking theirs, right? and send them on. However, I also recognize that it's just simply not that easy. And there's so many other pieces, to the implementation of the infrastructure that's necessary so that it does last. It's about sustainability. We can do lots of short-term projects, and we've done lots of short-term projects. In fact, I was talking with someone today, and what bothers me the most is the way that we start, stop. And every time we restart, we oftentimes are redoing what was done before. So there's a lot of duplication. But beginning to create conversations with people who are in those areas or are frequenting those areas know and understand that. But it's also ensuring, in our opinion, Minnesota has a very large African immigrant population. It's ensuring that that we reinforce the messaging that even though our ethnicity, our origins may not be the same, we share this lived experience of wanting to get better outcomes for sickle cell disease.
Yeah.
So if you're here in Minnesota, if you're in another state, connecting to your community-based organization, and let me rephrase that, community-based organizations connecting with you.
Yeah.
That the onus is on us, because they are an extension. They are still part of our community, but may not feel that we understand some of their lived experience. Their frame of reference is so very different than ours. And so I really am grateful that you are bringing your research, not just to us, but you're bringing it to areas where it's about studying what is best for this country.
Yeah.
That's
where I live.
Yeah, exactly. And so one of my other questions is, it's so funny. I was writing down questions and then you would hit them. I wrote down a question about stigma and then you were right on top of it. I wrote down a question about the plants and analgesics, natural analgesics. You answered that. Is there from an educational standpoint, because as I said, the influence of science does not look the same there as it does here. Is there a shared understanding of the difference between disease and trait, because there's no newborn screening, because many people may not know that they are carriers? How do you, other than having a child with it, right, or having pain yourself, how do you find out if you even have the trait?
Yeah, you have to be, and Shadia, I see your message and we will have you talk because I want to hear about this. I right now, especially particularly in Sierra Leone, it's really, if you are tapped into one of these community-based organizations, when they are doing screening, that is when you will find out. And I should also add here that screening for anything is a very sort of taboo in a way. It has a stigma attached to it. And so I recall an experience a woman came with her child and she wanted to get screened, and somehow it got misconstrued and back to her husband that she was getting screened for HIV. And so there was almost a fight at the community screening center because of this. Because number one, it's more of a patriarchal society. And so he didn't know, about this. And then also heard that it was a HIV screening, not a sickle cell screening. And so there, we had to do some counseling, right? Just even that example right there shows you the difference in understanding about what could someone be getting screened for, right? Versus there's this disease that everybody knows, which is HIV, that they're very scared of and has a very strong stigma. And so we're operating in an environment where there's already a well-established understanding of, like, if you're getting screened for something, it's probably HIV, right? And so it's about working within the community organizations to first do outreach, to explain what sickle cell disease is, just sickle cell disease. We haven't even gotten to trait yet. And so the trait piece, that is a whole other bag of whatever you want to call it, but it is not yet something that is a common knowledge, at least in Sierra Leone. Places like Nigeria, getting screened for sickle cell disease is quite commonplace now. It is part of your marriage counseling, actually. If you're going to get married in the Christian church, at least I know this, you have to be screened for sickle cell disease before they will let you marry each other. And there are pockets of places in Nigeria that do this newborn screening already. And then they're also able to screen adults. And so there's genetic counseling that is built in to the nurse's job, that people have become accustomed to the idea of sickle cell trait. But we don't have that yet in Sierra Leone. We don't have any sort of blanket education that is happening. If you're tapped into one of the community-based organizations focused on sickle cell, then yes. Yeah. Oh, we can't hear you, Miss Ray. You're on mute.
Thank you. I don't know that I would have ever thought about, I'm aware of the stigma, right, in various countries of Africa, and the stigma varies from country to country. I don't know that I would have ever thought about the HIV and the screening stigma for that. And so, just having these types of conversations are so incredibly helpful. And then just that basic education about disease, starting there, right? And are there, I know here, like in the US, we're trying to normalize community health workers. Yeah. My assumption is that, there are various individuals in the community that provide a sense of healing or a sense of education, even if they are not, a physician or a nurse, correct?
Yeah, I mean, the funny thing about that actually is community health workers and community health is commonplace.
Yes.
Public health is commonplace in these settings, which is not the case here, right? Ours is tertiary first, everything to the max. Yes. But in the communities that I've been working in, community health workers, your neighbor. I mean, there's one woman that I worked with who's been a nurse for my whole life, essentially. And she knows every single person in the community. She knows their house. She can walk straight to she knows their life. She knows when the kids were born. This is a very common thing.
Wow.
This is very, very common thing.
So then it's just a capacity. There's not enough of them to go around because of the sheer number of people.
Not enough
in the population.
Not enough infrastructure to, even if there were enough, then they need to collect data, and where we're going to put that data and who has the knowledge to manage the data. And so then that's a different capacity gap. But these are all things that we can mount each one of these challenges with due process and time.
So there's two things. Number one, I know that we have a young lady here from Uganda, and I'd like to promote her to panelists because I'd really like to hear from her. If you would just let me know in the chat if that's okay with you before I do it. And then my other question is, and this is a very direct question, really based on the history of colonialism. How do we ethically protect our brothers and sisters in Africa as we seek to increase capacity, as we seek to create infrastructure? We also want to make sure that, that there is There's ownership through education. So are they, in other words, don't just come over and take over the work, but teach, train, so that people can be self-sufficient. Is that part of the conversation as well?
Yeah, I think, I think 2020 really shook up the whole world, not just in the social sciences, if you will, or in the social aspects of things, but I think it really shed a lot of light on the practices of academia and science as well. There's a long history, not just in the United States, but on the continent of Africa too. And so I do believe that decolonization is part of this conversation. And I think also more and more scientists are now ascribing, and myself, has been my ethos since I was born, I think, that whatever I do should not be done for me, but for others. And whatever I think I need to do, I should check with somebody who actually knows first. Right. And so if you can operate from a framework that my knowledge is limited by my own experience,
yes,
you automatically have put yourself in a place to address the ethics of what you're doing, right? Because you're already removing, or at least attempting, because it's hard to do that. In Africa, in Nigeria and Sierra Leone, if they see you with a stethoscope, you're automatically a doctor, automatically.
wow.
And so there's a built-in hierarchy that you're just not going to get through culturally. You just have to own that. But your approach can dismantle some of the hierarchy that comes from the power differential, right? I'm coming with money, I'm coming with scientists, and I'm coming to this area that has been looking for that. It's like what Shadia is explaining. We need more resources to improve development and implementation, as well as research sustainability. And so I need to be aware that there is this need that I'm about to fill, but that need I'm about to fill does not give me the right to control any part of the research. At the end of the day, all of us should be focused on the greater good for the people. Yes, I have things I have to check off so that I can get an advancement in my career. That is true. But I was told by a very wise mentor, you don't chase the money, you chase the greater good for the people.
This is why we get along so well, because because it's true. If we adopt certain Western philosophies and mindsets, and it gets in the way of the greater good. It just does. And to your point, yes, we as residents of North America, right, we navigate our own country in the way that this country has been designed to operate, while still working to make things better, of course. But we have an opportunity, and I love that you said we also have to decolonize, because there are influences and there are powers that be that impact how we can do the work, and who has to give approval. There's a litany, right, of
yes,
that create barriers that shouldn't exist. The fact that we're talking about good, clean water, just that it should be a crime, a war crime. I mean, because the basic survival starts with water.
It really does.
And so it's very intentional, and not by accident that there are places around the world that still struggle with that, and those low resources. You showed the example of life expectancy in different countries. It's staggering, the difference. Staggering. These are our human brothers and sisters. And so Shadia, I want to give you a chance to talk. I'm gonna promote you to panelist, I think. Let's see if I can do that. It might not be allowing me. So, oh, there
Oh,
we
there
go.
she is.
There we go.
Good evening or good morning to you, Sadia. I think
morning.
it should be morning.
It is morning. Are you able to talk? And she may be multitasking as well.
Yeah.
Oh, let's see. Well, we'll wait to see if she comes on, because, you know, I find it very interesting
Oh,
that
there she is. I think she's here. Shadia.
Yes.
Hi.
we are. Hi,
Good
Shadia.
evening.
Oh,
I hope
wonderful.
you
We're
can
so
hear me.
glad you're here. We can see you.
I'm so happy I'm here. My name is Nasanga Shadia Malaika, and I'm the founder of Malaika Children Initiative. I don't know how much time I have to present to you, but I don't have my pitch deck ready because I'm just using my phone. Oh my God, I'm so excited.
Ah!
So I am the founder of Malaika Children Initiative. This is our t-shirt. And at Malaika Children Initiative, I am the team lead and the founder. We do awareness, acceptance, and advocacy for children and families that have diseases that do not heal. Those are chronic conditions and rare illnesses, and this includes sickle cell. The main reason why I started this is because I am the patient. I am the person who is affected by this. Because it has not been so easy for me growing up in a family like mine. Because when my father found out that I and my older brother had sickle cell, he left us. He separated my mother. Then my brother actually he was called Sesanga Arafat. So he died at the age of 3 years because of still the complications of sickle cell disease. So I'm lucky. I'm one of those that survived to adulthood. So I started Malaika Children Initiative in 2019. That was in Corona. Actually before Corona, but then I could no longer access the people that we were working with, the families that I were helping, and that is why I came up with Immune, the mobile application that I want you to know about.
Oh.
Many of the families that I'm working with are actually affected by sickle cell disease, just like I am. For me, I have this organization and I have made some friends, and that is why I can now access the medicine, the hydroxyurea you're talking about. It is very expensive. Not everyone can get it. And then even today, I was in the hospital getting my medical lab, so we had to do kidney checkups, liver, and all these things are expensive.
Yeah.
So at Malaika Children Initiative, we came up with this initiative called Immune. Okay, I intend to make people like us immune because we are always in the hospital, and am I rushing?
No, you're fine.
No, you're doing wonderful.
Yeah.
Thank you. So we want to make people with children actually with sickle cell disease immune to the complications of sickle cell, because that is what our doctors are always worried about, and our parents. Oh, I did not introduce myself to you very well. I'm a student at Macquarie University. I'm doing a bachelor's degree in information systems and technology, and I'm 23 years old now. Yes, I thank God.
Yay.
So we are making these children immune to all the complications of sickle cell disease. You would wonder how. So my problem statement, okay, I'll tell you the problem that we discovered for this project. There is high mortality rates and high morbidity cases in sickle cell disease pediatric patients. And this is mainly in my country, mainly because of poor accessibility and follow-up for treatment. And then inaccessibility to medical personnel. There's so many other problems. So those were the main three that we found out. So our solution is a mobile application that can manage them remotely.
Nice.
And then this mobile application is both online and offline. So you can use it using data, using USSD codes, and our SMSs, and our toll-free number, and our toll-free call number. So we intend to have a call center SMSs where we can tell, hello, Shadia, you have your appointment on Wednesday at 2 p.m. Please go and see Dr. Namaganda. She'll be working on you, something like that.
Wow.
So that system, what makes our value proposition unique is that we are scheduling now appointments. We are decentralizing treatment sickle cell disease patients from the main national referral, that is Mulago Sickle Cell Clinic. Now we want to work with the government health center for hospitals, whereby we have these, your neighbor, the people who are working at the health center for hospitals know very well these people who live within. So we want to utilize those available resources. We go there, implement our application, whereby, we are not hoping on training new specialists in hematology, but we want to get those health officers that are there, and then we train them using our own pediatricians that we have in the hematology. So that is the best way, because getting new specialists will be a bit very expensive, which you can't manage. So we are working in the government health center for hospitals, and then in that way, it will be better for us to advocate for this infrastructure. That is, these machines that do the HB electrophoresis, getting the apheresis machines. For example, in Uganda, we only have one apheresis machine, which is very bad, and it is only accessible to the rich. So it will be easier for us to better advocate for that. And then the other thing, I noted down some things. So you schedule appointments with your doctor, yes. So it's not like now where people just move long distances. Imagine someone from southern Uganda or northern Uganda coming to the central to get hydroxyurea. Imagine. Yet these people are very poor, and we all know that. So then as well, for the national program, implementing the national screening program, we would as well use our application to track down these numbers. And then we have that already in our business model, just that I don't have the resources, the access to go to the people who can help us. And then in the same application, your doctor, for example, my doctor, after scheduling appointment, I see my doctor, we request lab requests still on the application, they are still kept on the app, because here currently in Uganda, we use physical books like this one.
Yes.
Go to the national referral at our sickle cell clinic or any other clinic, they write your name.
Yes.
How are you feeling, Shadia? My head is paining. I have pain in the chest. So they take that down. If you get to lose this book,
That's it.
you won't get treatment again.
Yeah.
Yes, you have to get this book, another book, and if you get to forget your number, your sickle cell identification number at the clinic, you will not get worked on. So we are solving all that on the application, which is actually our patients, our clients will not be paying because they don't have money. Even I, the founder, the team lead, I don't want to cry. I also don't have the money to afford what I'm providing. So even buying a hydroxyurea, one tablet like this is very expensive for me. Not even my mom can manage.
Right.
But okay.
You're doing great. That's okay. We're grateful.
Grateful. Exactly. That's the word that comes to mind. And Shadia, I had to fight off tears earlier while you were talking, because I am inspired. I started this organization and because I have a son that lives with sickle cell disease. And so you, as a person living with sickle cell disease who is taking this on, you are changing your country. You are advancing the work that's being done and the lives that will benefit, including your own. And so I don't know how you discovered us today, but today is a new day, and it's about having the network and the connection to have the individuals to talk to see where help can come.
Yeah.
Thank you. Maybe I think I didn't mention about my team. I am a student at Makerere University, so I was assigned to the Makerere University Innovation and Incubation Center at the College of Computing, my school where I study from. and we are working. I'm working with Mr. Kajubi. I'm working with one pediatrician, okay, one hematologist, a specialist called Dr. Namaganda. Then there is also Mr. Moses. He's working at Entebbe Referral. Then Mr. Kasozi, he's working at Chirudu, all those main hospitals. So they tell us what is lacking, and then we want to implement. Okay, we have so much we want to bring
Yeah.
onto this application,
Yeah.
but as Shadia and Malaika Children Initiative and Macquarie University, I don't have the resources. I have tried to apply for different grants, but they say they want big organizations, yet I'm only a CBO. I just started in 2019. And the money I'm using in my CBO is just from my fruits. Imagine I just sell strawberries, and if I can't even get some money to like support my medicine, so my friends just give me money to use in the CBO and advocate for the people. So I
Well,
don't know.
what I would love for you to do, if you can send your email to host and panelists, and that way both Stephanie and I have your contact information.
Yeah.
And we will connect with you.
Yes,
Okay,
we will.
how can I send it?
You can put it, if you go to the chat.
Yes.
And you should click on the chat and you'll be able to change who you're sending it to on
Yes,
the chat.
and if you can't, that's okay. We can still see it.
Yeah.
All right. Thank you so much.
Yeah, just put your email down there and we'll continue speaking. Thank you so much for sharing.
Thank you so much. We so appreciate you sharing with us.
You're welcome.
And I'm going to remove the spotlight.
Thank you.
Thank you. Thank you so much. This is why we do what we do. This is why it is so important to us to speak up and be unapologetic in the work that we are doing, not just here in the US, but even though our resources, we feel that our resources are limited. My dog knows that I'm on camera. Even though we believe that our resources are limited, and in context, to some degree it is, but when we look at what resources are lacking elsewhere, I think it just allows us to put everything into perspective.
Really, it does.
It allows us to approach our work with humility. It allows us to involve communities who don't have the same access. And we have to see that our resources are also knowledge. Our resources is also our network. Our resources, is also our education and awareness tools.
Yes.
And so even when we don't only have money, we have other things that we believe can add to your resource bank.
Yes, that's absolutely right.
That's what at least that's what, I won't speak for you, Stephanie, but I know you're doing amazing things as well. So anything you'd like to add?
I wholeheartedly agree with you. I think sometimes, when we think about resources, that's why it's always so complicated when we start talking about low income to middle income countries. That phrase is really about the income of each person per capita, right? But then when you get down to the nitty gritty of what kind of resource is really needed in this so-called low resource context, like what the brilliant, probably future doctor, masters of everything, Shadia has said, sometimes the resource is making the connection so that you can get the financial, right, piece. And so I have goosebumps listening to young Shadia. I remember the passion that I had at that age. I know I'm not much older than her, but as you grow in your knowledge of something, you can sometimes forget or feel tired. And so today I just got re-inspired again by Shadia, and I look forward to connecting with her. And I'm so appreciative of Dr. Nielsen coming and joining us today. It is very overwhelming, the disparity between the United States and Sub-Saharan Africa. And I frankly refuse to stand for it anymore.
That's right.
And so that is where my passion comes from. That's where I come from. I know my address in Nigeria. I know where to go, and I am lucky that I have that ability, right? And that is something that I will not take for granted. That is a privilege. And so I will use my privilege. As I told somebody the other day, I will leverage my Nigerianness to ensure that that disparity is addressed, whether it is in the little pond that I have a circle of influence around. I will make ripples, and I'm very happy to be here with you all and talking about this.
Wow. Oh, I too have goosebumps. I am, there's so much I could say, but I absolutely want to say thank you to Shadia. I do want to say thank you to Dr. Nelson for being here, who goes to and fro from Sierra Leone as well, and looking to help to steer resources into that area. So many areas, Uganda. I would not have known about the Immune mobile app if it weren't for you, Shadia. Nothing happens by accident. My faith tells me things don't happen on accident. They're very purposeful. And so, but Dr. Ibamire, I want to again say how grateful we are. I'm screen sharing right now just so that I make sure I don't forget anything, because I get emotional and I'll forget everything. But I do want to say also that there is an email on the screen if you'd like to reach out to Dr. Ibamire, as well as if you are on social media on LinkedIn, you can find both her and myself on there. Sickle Cell Foundation of Minnesota is who we are, and we can be found on there as well. I will also bring to your remembrance that last month, September, was Sickle Cell Awareness Month, and that's when we started our East Meets West series. Because it was all about reaching beyond, and it's about taking a humble approach to the work that we are doing here in the US, and bringing our brothers and sisters along in whatever way that we can. And so, like hearts meet, I do believe you can stay up to date with our events. You can learn more about our SickleSMART program through our website, sicklecellmn.org. You can also subscribe to our YouTube channel. Now, YouTube is funny because you have to subscribe and don't forget to click the little bell. So it tells you when we upload. Like they made a two-step process. And then Eventbrite is where we post all of our in-person and virtual events. We invite you to be a part of that. Not only did we have East Meets West last month, but we also had health disparities and inequities. Yes, our mutual friend.
We love to see it.
Yes, it's on our YouTube channel already. And so you can reach it there. Just a reminder, I will never stop saying this, and that is, if you really want to lend a hand, lend an arm, we need more diverse blood donors. We're already in a shortage, and anytime there is a shortage, we know that groups that suffer great disparities experience it the greatest. And so we have to make sure that we are our cure. And we are. It's amazing the resources that we have within. That word is just going to ring in me in so many ways, because it's not, resources is not just about money. Now, don't get me wrong. It is, we need them.
We need the dollar bills.
Right?
Yes, we do.
Or whatever the dollars are in your country, it's still needed. But we have to look bigger than that. We can't just throw money and not understand that there's this infrastructure and there's these connections that are necessary. So y'all know I can go on forever. So please donate blood. And then if you'd like to learn more about why we need to diversify the blood donor pool, we have a video for that. You know how they say we got an app for that? We got a video for that.
I love this.
And then of course, Be the Match. There is a cure available. It's not available to all. It's available to some, but we can increase the number of the some by joining that registry. The very same reason that we need more diversity in blood donors is the reason that we need more diversity on the Be the Match registry for stem cell transplant. And then if you are a person living with sickle cell disease, you can go to sicklecellconnect.com. You could also be a caregiver or even a provider. And you can order this packet that talks a lot more about curative therapy options, particularly stem cell transplant. And then our monthly activities, every month we have our cooking class where you can learn how to use more anti-inflammatory ingredients. If you live in the US, we have what's called the standard American diet, also known as the SAD diet, because that is exactly what it is. And it actually worsens our health outcomes while they sell it to us. So that's all I'm going to say on that, because I don't want to get sued. And then, as I said, we also have a monthly support group that meets on the last Thursday of every month. It is not just for Minnesota. It is for wherever you are. It is adolescents and adults ages 16 and up. It's a safe place to be able to come and talk, meet others, and just talk through some of the challenges of living it. But we have a focus on solutions. It's about finding solutions, and we are champions and we are overcomers. And so we really seek to celebrate the ways that we learn how to be champions and overcomers. And then, of course, school support. If you're local here in Minnesota, we do provide school support, everything from assisting with purchasing books if you're in post-secondary, to even school meals if you as a caregiver or even a high school student are struggling to purchase meals while you're at school. It's hard to learn on an empty stomach. And then, of course, our SickleSMART, be sure to join us signing up. You can follow us on Eventbrite as well. Another thing that we have, and this is for everyone, regardless to where you're at, this is Our Voices Matter. We want to give a voice to the voiceless. We want you to tell your story. We want you to share your medical experiences. And we're not just talking about the negative ones. We want to know what good is happening out there. Why? We want to celebrate who our champions are. We don't want them to think that they're not doing anything right. We want them to know how much we appreciate them. We at Sickle Cell Foundation of Minnesota, we get calls, we get emails saying, I just moved to Minnesota. I'm planning to move to Minnesota. Where should I go to where can I find a good physician? We want to hear that from you all. You all are the ones who are visiting with these physicians and can give us that feedback. But we also want to know when you're not having great experiences, because when we are sitting at tables of influence, and y'all know, if y'all know Ray does not mind speaking truth to power. We want to be able to use clear lived experiences. No, we don't use your name. No, we don't, say anything about who you are, but we do hold institutions responsible. And when it is necessary, we hold individuals responsible. And we expect to have conversation with these institutions around that. So by all means, you can use our form at Our Voices Matter Too. Of course, that's bit.ly. We always use bit.ly. Our Voices Matter Too. All right. Just another reminder, please support our partners. Children's Minnesota Agios has a great clinical trial that is starting, that is very exciting. Memorial Blood Centers has a sickle cell donor program that is specifically geared towards making sure that they keep the right units on the shelves for individuals with sickle cell who are in desperate need of transfusions. Be the Match, of course, we partner with them as well. And then Minnesota is one of the 11 states who are receiving, who are participating in the sickle cell disease data collection project. We want that to expand to all the states. We're proud to be one of the 11 states, but there's 40 plus states more that need 30 states more, no, 40 states more that need that same program. My saying, and then I'm going to depart on this: no data, no dollars, no dollars, no research, no cure. We have to understand the value of how data is going to get us to our cure. That's what we need. And so when it comes to participating in data collection, when it comes to participating in clinical trials, we don't want anything about us without us. We are our cure. We have to participate. I don't need another textbook that is using standard European models to decide how our bodies work. Yes, there is a lot of overlap, but there are also unique things that must be called out and must be better understood. So with that being said, I'm like you, Dr. Abamira, I could go on and on because I'm just that passionate about my community. This is my community. We are a community. If the house is on fire and I'm standing on the outside, I'm trying to help them. I'm on the inside of the house that's on fire and I'm helping us.
That's absolutely right. I'm right there with you. I got the hose and everything.
That's right, right?
Yes.
We're on the inside. We're not on the
Yes.
outside. And every doctor that cares for sickle cell, you're on the inside of the house that's on fire. Every nurse that cares for sickle cell disease, you're on the inside of the house that's on fire. Every person living with sickle cell disease, Lord knows you're on the inside of the house, but know that you're not alone. So we thank you for
Absolutely.
joining us today. Dr. Abamira, I'll ask that you just stay on for a few more minutes, but thank you, thank you, thank you. Stay up to date with us and we look forward to seeing you at our next events. Take care.